Hello and good morning, everyone. Nice to be here with all of you again today. Welcome to the second day of the ACH HCA Learning Symposium 2021. I'm Bonnie Wennerstrom with HCA, your NC for this event. It's really nice to be with all of you this morning. We have three great panels today, including this one on addressing social determinants of health. Our second panel is focused on youth, especially elevating the voice of youth and families in healthcare delivery. And our third and final session for the day is focused on tribal partnerships. Before we get started, I want to remind you of a couple things related to Zoom housekeeping. So the audience, that's you, is muted and your video cameras are turned off. You should only see the panelists and slides when they are shown. If you have technology issues, please put that into the chat. There's only the option to chat the panelists, not the entire audience. Our tech folks will see your chats to the panelists and get back to you individually, also via the chat. If you have questions for the speakers, please use the Q&A box and we'll do our best to get to as many questions as possible. And both the Q&A function and both the chat and the Q&A function should be at the bottom of your screen. Just taking a pause here to make sure, am I talking to lots of people or just a couple of people?
It's still in practice, Bonnie.
Oh, great, okay. I can't see anything from what I'm doing, so darn.
But you did amazing, Bonnie. You did amazing.
Yeah.
Thanks, Jean. I can do that again. All right, I'm gonna go
Tiffany,
back.
I'm gonna start webinar right now.
Okay, thanks, Nick.
I'm gonna go dark. Good morning, everyone. So nice to be with all of you today. Welcome to the second day of the HCA ACH Learning Symposium 2021. I'm Bonnie Wennerstrom, your host and MC for this event. We're so glad you're here with us today. We have three great panels, including this one on addressing the social determinants of health. Our second panel today is focused on youth, especially elevating the voice of youth and families in healthcare delivery. Then we have a third and final session today on tribal partnerships, which should be really great as well. Before we get started, I'd like to remind you about just a few things related to Zoom housekeeping. So the audience, that's all of you, is muted and your video cameras are turned off. You should only see the slides and the panelists when they are shown. If you have any technology issues, please put those into the chat. There's only the option to chat the panelists, not the entire audience. Our tech folks will see your chats to the panelists and will get back to you individually, also via the chat. If you have questions for speakers during any of the sessions, please use the Q&A function for that. And we'll do our best to get to as many questions as possible. We had some really great and thought-provoking questions during the sessions and speakers yesterday, so please keep that up. Both the chat and the Q&A function should be at the bottom of your screen. So tech issues go in the chat, questions for speakers and panelists go in the Q&A box. As a reminder, we're recording all of the sessions and copies of all of the materials will be available on the website after the conference concludes. The website is www.washingtonach.org. And now let me turn things over to your moderator for this session, Jean Clark, the Executive Director of Cascade Pacific Action Alliance. Jean, please go ahead.
Good morning, everyone, and thank you all for being here for the Addressing Social Determinants of Health Needs session. I hope you all have a nice cup of coffee or whatever your beverage of choice is, and sit back and enjoy today's session. We have a wonderful panel this morning that I'll quickly introduce to you before we get started. Just so you know, everyone's bios for each of these speakers will be put into the chat. First, we have Darren Nelson Souza from CMAR Community Health. Next, we have Lindsay Boswell and Sharon Miracle from Yakima Valley Community Foundation. Then Amy Brandt with Olympic Community of Health. And last but not least, Jody Castle with Elevate Health. Each of our panelists will share a presentation of their work, and then we'll use the last about 15 or 20 minutes of our time for questions and answers. As Bonnie mentioned, please use the Q&A box to submit your question. And we'll do our very best to get to as many of them as possible later in the session. But now let's begin first, and we'll hear from Darren Nelson Souza. Darren.
Thank you, Jean. Good morning, everyone. I am the care manager from CMAR Community Health, and I work with a team of care coordinators, integration specialists, case managers, and community health workers. We are very fortunate to be tightly wound up with our ACH, known as Swatch, due to a lot of circumstances that have been pretty amazing for me. And what I really want to share with us today is just some of the social determinants of health that we encounter, and why I want to kind of highlight how we can overcome at least one of them with a pretty simple fix. So let's start by talking about the whole person care. So whole person care is a concept that is on the premise that the recognition of the best way to care for people with complex needs is to consider their whole spectrum of needs, their medical needs, their behavioral health, social, economic, spiritual, and beyond. Coordination of care or coordination of health includes the behavioral health and the social services that are patient-centered. The goal of the whole program is to improve health outcomes and more efficient and effective ways of using resources. We find so often that several agencies are working on the same area with the same client, and we kind of bump into each other. So we want to figure out ways to limit that, kind of bumping into other organizations, and let the experts really take over and us do something else. So the Accountable Community of Health in Southwest Washington kind of spearheaded, go ahead and change the slide if you would, spearheaded the development of the Health Connect Regional Hub. It's a centralized community-based care coordination infrastructure. So it provides us with workforce development, provides a diverse community voice, works closely with each of the workers and with each of the managers within the teams. The hub, in collaboration with Health Connect integrated partners such as CMAR, other grassroots organizations, other community partners, other public health, managed care organizations, and health systems, we work to ensure that social and healthcare needs are addressed and to try to assess gaps in order to meet a whole person healthcare system. By collaborating as a community to share the strength and to address some of the challenges, the partner agencies, we work together to improve systems and address gaps across the spectrum of care and services. Clients referred through the hub process are assigned to partner agencies with culturally specific community health workers who have lived experience in common with the client. Language barriers, which we'll talk more about later, are huge when trying to achieve adequate care anywhere. By using this kind of smart assignment in both the Health Homes program and our Pathways programs, we're able to, at CMAR, support Russian, Spanish, Korean, English, and a few other languages, I think, with people who could speak a little bit of something. With the use of translation services, they're available and they help to widen the scope of our work. Due to the nature of the work that we're able to do, we used to be able to see clients in their home or other community settings. Remember pre-COVID. it was really an interesting process of going into people's homes or meeting them in community settings to really kind of get a visual on some of the possible client needs. So with us going to phone calls, that's kind of, you really have to work to get the information from some clients. To help our workforce kind of address many of the social determinants of health, like transportation, housing, food security, it's easier to see those things when you're in their environment. And I can't wait until this precaution gets limited a little bit, because the relationship that happens within care coordination is due to the trust that the care coordinator or the community health worker or the community-based worker develops with the client. The more you know the client, the more they're going to trust you. When we do what we say we're going to do, when we say we're going to do it, it builds a strong bond. So we find our clients, we figure out how to help them. And then due to the addition of the infrastructure, the data infrastructure that Swatch brings to us, we can measure that. We can talk about housing and lack of transportation and those kind of issues. You can go ahead, Kathy, and change slides. Thank you. So just, we could talk all day about transportation and housing and food security and all of the social determinants that we're all very aware of. But I think there's one major social determinant that we can, as a community, attack. It's the language barrier. The lack of cultural specific and positive care often will create a culture of distrust towards an individual's healthcare. And what I've discovered is that if we're not meeting the needs of one individual in a community, that word gets spread very quickly and then nobody comes because they're a tight-knit group. So if we're gonna address some of the other social determinants of health, I think we need to have some major shifts in policies, just developing more robust transportation systems or building more affordable. I say affordable because it should be considered more low income housing systems. But anyway, the language barrier is something that CMAR, Health Homes, Pathways, Health Connect have all worked together to hire many bilingual individuals to address our lack of systems. The translation services that we have available are really pretty robust and able to meet the need, but at best, it's difficult. And if you don't understand your client and you're working with a translator, it can be doubly difficult. So we really want to know what a client needs in their language so that they're comfortable to tell us what's going on and what we can do to help. One of the things that Swatch has really instilled in me as a manager is the conversation about what that looks like. And I dare say that without a little prodding and pushing from Swatch and discussions about barriers and how we can address them, we get stuck in a rut and we don't think outside the box. And so I appreciate what Swatch has done with our team to help us think outside the box. I want to share with you a story before I turn this off back to Jean. We have Health Homes and Pathways teams. We hired a Russian, Korean speaking woman to work with our community-based work program in Pathways. She started, I think, in May. And after a lot of working, because English isn't her first language, I think we've got her kind of caught up in systems and how to document things and make sure that we have the information. But her entire caseload is Russian speaking. That's amazing. It's like build it and they will come, right? So then on my other team in Health Homes, I thought, well, goodness sakes, let's do this again. So I hired a gentleman who is Russian, Spanish, and English speaking. And he, his caseload is probably 90% Russian speaking, and he's done a tremendous job. Not to say that the rest of the team hasn't worked to do what we need to do. Our Spanish speakers are helping with translating and working with clients that are Spanish speaking. And of course, our English folks are just rocking it like they usually do. And we're using translation services. So if we want to address a barrier, we might have to think outside of the box to come up with a way to address that. And for us at CMAR, we were developed to help migrant undocumented farm workers in the Seattle-Marysville area. And CMAR has grown exponentially over the years, but they've kind of stayed in the box of Spanish. And it's really a beautiful thing to step outside that box, open up the language, and bring in more clients and be able to help support more people. I'm thankful for the work that Swatch has done to help us kind of jump in and address some of the needs within our community for our Spanish, Russian, Korean speakers. We have Vietnamese speakers. Clark County is this kind of microcosm of the world, I think. And so as we grow and develop, I'm counting on Swatch to help us continue to open those doors and break down these barriers within language. Thank you, Jean.
Darren, thank you so very much. It sounds like your partnership with Swatch has been really helping to move the dial on helping individuals. And just as you said, that language support is huge. I'm guessing that not meeting in person, you miss all of those visual cues. And so being able to at least speak better the language would be very helpful. Thank you so much, Darren.
Thank you, Jean.
You're welcome. We're going to go ahead and move towards our next speaker. We have Sharon Miracle and Lindsay Boswell presenting next. Ladies.
Good morning, everyone. I'm Sharon Miracle. I'm the president and CEO of the Yakima Valley Community Foundation, and we are the third-party administrator for the Greater Columbia ACH. And I'm here to explain a little bit about our role and primarily how it's been a great partnership in terms of where we're aligned around equity. And, as you know, the ACHs were established to align with equity around our Medicaid population. So this is a little overview of that, and then I'll kick it over to Lindsay to talk about how we handled our third-party administration with an equity lens. Next, please. So the role of a community foundation works perfectly for this. This is our mission on top. We connect people, resources, and ideas. And we primarily serve Yakima Valley or Yakima County and also Kittitas. And we've expanded that most recently to Central Washington. But a community foundation, of which there are 800 of them across the nation, plays three primary roles. One, we're a convener of people, resources, and ideas. Two, we actually grow endowments and other charitable funds for the community that we serve. And we did a really nice job, or I guess I'm patting ourselves on the back, but it worked really well with the ACH partnership to braid these funds together to actually increase them for community impact with health equity. And then the third role we do is community leadership. And that pieces that we jump into really complex issues where it takes pulling people together and resources together to solve those. And that's exactly what ACHs are designed to do as well. So it's a nice alignment here. Next slide. When I said equity, we began our journey into this lens of equity or commitment to equity a little over 3 years ago before I arrived at the organization. And we made a very strong commitment from the board level on and hired 2 consultants to actually meet with us every single month. We have deep dived our own personal journeys into our vision of or understanding of race and dismantling all of those conditions and understanding our biases, and then look through policies and change bylaws, grant processes, et cetera, and really trying to make this as equitable as possible for individuals and organizations in our community. This is our commitment to equity, and I encourage you to visit our website if you'd actually like to see our equity statement, which we put forth and include in all of our grant documentation as well. And Lindsay is going to take it from here and describe how we applied the equity lens to our granting process.
Excellent. Thank you, Sharon. Good morning, everybody. So I was just going to talk a little bit about the partnership that we had with our local health improvement network, the Yakima County Healthcare Coalition, in braiding some funding together to support work in social determinants of health with a specific focus on health equity. We've actually been really fortunate that we've been able to partner now twice with both our Kittitas and our Yakima County local health improvement network. So in 2019, we were able to actually just about match the amount of funding that came from GCACH to put together some 3-year grants, which is a really important tool for building capacity with organizations, because that multi-year funding really helps to build some sustainability and consistency. And the thing that I wanted to talk about in particular with our 2019 work was that it aligned very nicely without seemingly like a lot of effort, which at first you think maybe that's just luck. But what happened was we were approached to serve as a third-party administrator by our local health improvement network. And it happened that our own grant committee had been created a focus on health equity for our grant. So the alignment was extraordinarily in sync between those two parties, which, like I said, you could attribute to luck, but I actually like to think that it's more about we were both doing really committed work to focusing on health equity and paying attention to what's happening in our communities so that we understood the work that needed to happen. Go ahead and hit the next slide, Kathy. And so again, we were able to, this is from our 2021 application cycle, we were again able to braid some funding together because there was so much uncertainty in the world. We only did 1-year grants at this time, but because it's hard to plan for 3 years at this point with the uncertainties around COVID. But what we actually saw through our reporting process was a lot of those capacity building multi-year grants that we made in 2019, we could already see the progress happening with those grantees. And so the 1-year grants now became an enhance or expansion of programming that they had already rooted pretty well in their organization, which is a really great and exciting thing to see as a funder. And so it also highlights, I think, the value of time as a commodity that funders can control and are really important for concepts around equity and providing ample time for organizations to really get the work done that they're looking to do. Those little picture snapshots on the bottom are from some of our conversation-based reporting process that we have put in place for the last couple of years, which is really fun. And I'd love to tell you about that in a different time and space. Let's see, go ahead to the next slide, Kathy. I think that's our last one. Yeah, so again, thank you for letting us present this morning. We're looking forward to dialogue and questions. This is our contact info to include one of our colleagues, Estacio, who's also, I think, attending the conference here today. So you can find him in another session too. Thanks, Jean.
Oh my gosh. Sharon and Lindsay, thank you so much for sharing your work on equity. And I applaud you for moving that forward. And encouraging others to possibly do the same. I'm sure we'll have questions in a little bit for you, but again, thank you. We're going to go ahead and move forward with Amy Brandt. Amy, if you would please share your work.
Thanks, Jean. Hello, my name is Amy Brandt, and I'm the Communications Coordinator at Olympic Community of Health, or OCH. Today, I'm going to share with you a tool that OCH has created to take stock of local projects addressing determinants of health. OCH is the accountable community of health working in the Olympic region, and collaboration is at the core of our work. And this inventory is just one way that we foster collaborative problem solving, ultimately fostering a region of healthy people, thriving communities. A reoccurring theme that we keep hearing from our partners is this need and importance of working together on these challenging health issues. A partner shared with us, being innovative with partnerships is important. You'd be surprised by who is interested in partnering with you and why. It's another way to understand what your community needs. The work that our region sets out to do is really challenging work with a long road ahead. And by working together, we can ultimately create more meaningful health impacts. So through several research activities that OCH conducted in 2020, it became really apparent that there are a ton of innovative projects happening all across the region, but there's nowhere to see who's working on what in one place. So let's say I was interested in implementing a food access program, but first wanted to see what others have done and succeeded at. I wouldn't know where to start, where to look. So thus, the inventory of local projects was born. This digital inventory that I'm about to share with you was created to build situational awareness, inspire future projects and collaboration, and visually display current outreach and gaps. It's not a comprehensive tool and wasn't designed to be a directory, but rather a balance board for creativity and partnership. So this next slide is going to have a URL, and I'll put it in the chat for everyone here. And it'll be in the presentation materials that are accessible on this event's website. I'm just going to take you on a little tour of this webpage. So the beginning of the web page introduces you to the tool. It identifies the purpose and provides some links to some more background information. It goes into some of the findings from OCH's previous reports and research. And this section really sets the stage for why it's important to address determinants of health. Scrolling down a bit, you'll see this interactive map, and this is really the heart of the inventory. This map features over 60 projects related to financial strain, healthy, affordable food access, housing, and transportation. You can easily navigate by clicking on the categories on the left, but from this homepage already, you can see that there's a wide variety of projects spanning all the way from the coast of Clallam County to the Puget Sound area of Kitsap. So I'm going to zoom in a bit more and show you what we can learn from the map. As you explore the tool by clicking on an organization or tribe, a panel will appear with a description about the project. For example, by clicking on Fishline Food Bank, we can learn how they are creatively addressing food access in the North Kitsap area via their fresh market, their Grow a Row program, and their partnership with local farmers markets. The inventory also shows us who is being reached by this project. So if we look at the map, there's this green layer, this region that appeared, and this denotes the outreach of Fishline Food Bank. These highlighted regions aren't restricted to zip code or city limits, as they represent a broader access pattern. So just because the food bank is in Paulsbo, Washington, doesn't mean it's restricted and limited to Paulsbo residents. So this approach to this more pattern-based region gives us a better idea of the outreach of each project as opposed to just the physical location. Some organizations serve several subregions. A good example of this is Oxford House. So not only do they serve Kitsap County, but they also serve community members in Port Angeles. Oxford House is a great example of a local organization providing housing for individuals recovering from addiction. You can also see, if we look at their Kitsap icon, just to the right of them is another organization working on housing as well. So we envision this tool to be a source of curiosity and exploration as our partners across the region build awareness of what their neighbors are working on, and ideally collaborate and support one another on these really tough topics. Scrolling further down the website is a section focused on access to healthcare. This section has a data dashboard with 5 metrics related to access to healthcare. The data reflects Medicaid members at a zip code level, which is different from what we're used to, which we're used to seeing county level or regional data. So this zip code level data allows us to take a deeper dive and start looking at and exploring the leading causes of what's leading to success and challenges across the region. We also have these blue boxes that have a snapshot on the left that describe some of our implementation partners, the ways that they are addressing access to healthcare. So, for example, Peninsula Behavioral Health is an organization, a partner of ours, that works to create a process for reintegration for incarcerated individuals who are re-entering Clallam. Their resource guide provides resources and information about where to get behavioral health services, primary care, housing services, restarting your government benefits, and making sure that their basic needs are met. Lastly, as you scroll to the bottom of the page, we just described some information and opportunities for action. How can you get involved? We really envision this tool to serve as a resource that encourages our partners to learn more about each other's projects and think about how they can address determinants of health in their community. And finally, this tool is meant to grow. We know there are probably way more projects out there that aren't yet accounted for in this map. So there's this form at the bottom that people could let us know what they're working on across the Olympic region so that we can embed these projects into our map. So that concludes my virtual tour of this inventory. OCH is really excited to see how this resource will grow and continue to support collaboration across the Olympic region. Thanks, Jean.
Amy, thank you so much. I personally am a visual person, so I love the map versus just information in a written or a verbal modality. So thank you so much for sharing. We're going to move to our last speaker for this session, and then of course we'll do some questions and answers. But I'd like to turn it over to Jody Castle now.
Hi. Thank you, Jean. Thank you everyone for allowing me to be here. This is my first learning symposium, so I'm really excited to talk to you a little bit about the work Elevate Health has been doing around social determinants of health, particularly in the area of data. As many of you know, or may or may not know, I should say, we've done a lot of work with community-based care coordination at the micro level and the collection of social determinants of health at that level, which has led us to want to know more about what is happening across the community in regards to social determinants of health. And so we have been working on a new initiative with our data partner, our technology partners with Innovaser. And we wanted to present to you today a use case whereby we were looking at the impact of social determinants of health and other non-clinical factors on health outcomes. And so please keep in mind, this is just one use case, but what we're really trying to look at here is how we can aggregate data that is available to us currently. We have a roadmap for development with the community as well. But in the meantime, we wanted to look at what we could potentially do with some open source data and looking at social determinants of health across our community. And so I will make the disclaimer that I am a social worker. I am not a data scientist. I would have loved for Innovaser to come and present this for us, but their engineers are in India, so that made it a little bit difficult. So, but if there are more technological questions after, I am happy to obtain some answers for anybody who might be interested. Next slide, please. So as we look at our use case, we wanted to provide you some information in regards to the data sources and methodology. So with this particular use case, Innovaser used University of Wisconsin Population Health Institute data, and they have a program called the Community Health Rankings and Roadmaps. And this works to improve health outcomes for everyone and to close health disparities. And so really, they have looked at the data across all communities. And so this was a good place for us to start with in terms of looking at Washington in particular. And so what Innovaser did was they looked at the data from the County Health Rankings and Roadmap program, and they did some correlational studies with the Social Vulnerability Index. Some of you may be familiar with the Social Vulnerability Index through the CDC, which looks in kind at social determinants of health data. What Innovaser has done is they've developed a proprietary tool whereby they have deduced and reduced some of those individual factors down to 7 measures. So Innovaser's proprietary tool looks at socioeconomic index, housing composition, minority status and language, housing and transportation, lifestyle, and access to healthcare and food security. So essentially, via more complex algorithms, they have cohorted some of these measures. So just so you're aware, we're looking at a smaller scope in terms of those measures that have actually been compiled together. And in terms of methodology, we really wanted to look at factors leading to positive or negative health outcomes as we compared the SVI scores against the data from University of Wisconsin. And we did a correlational analysis between health outcomes and social determinants by way of the Social Vulnerability Index to look at potential opportunities for intervention to improve overall county and then hopefully thereby state health. And the goal of this, right, would be to obviously look at the different dynamics of the county, but also how that folds up into state level data. Next slide, please. So here, and I know this is a busy slide and I apologize, any of these data slides are really hard to deduce to a few slides, but we wanted to kind of show you here how Innovaccer's SVI scores or social determinant of health scores have correlations with the public health ranking markers that they looked at. And so you'll see on the right that we have the SVI factors listed out according to the health factors ranking. And so I just wanted to draw your attention to that. The dark green in this means that they have a strong positive correlation. So for example, in the health factors rank under SVI factors, socioeconomic and housing and transportation have very strong positive correlations and impact, whereby if you look down that column at the red for lifestyle, those are negative correlations, also strong correlations, but have a negative impact. So lifestyle can potentially have a very negative impact on the health factors ranking. So to the left, you'll see that we've summarized some of those findings. And really looking at some of the call outs when we looked at these correlations against each other. So for example, I'll allow you all to look through some of these when we send the slides out, but the socioeconomic SVI score, or what I'm going to call the social determinants of health score, because I am not a data scientist and I need to deduce it to that level, but socioeconomic, essentially social determinant of health score, there was a strong correlation with all the ranking variables and factors such as economic status, unemployment rate, and number of schools showed a major impact on health outcomes. And so this is a way for us to really kind of look at in a more systematic way what we already know or we think we know. And so I think this is a really good place to begin. And so this is what we did initially, was to look at this across Washington state, and just to make sure that we're looking at those SVI scores against those public health rankings to establish correlational strength. And it looks like many of them did have strong correlations. And so this gives us an indication of the areas that we really want to focus on that have shown to have positive outcomes across these different types of rankings. Next slide, please. So here, this is just a really nice heat map. And when we looked at these scores across Washington, I thought it was really nice to call out, because we have different areas of representation here, that the areas that really were associated with strong health outcomes. So good socioeconomic supports, access to healthcare, housing, and transportation scores really indicated strong health outcomes. And I also wanted to kind of note for you here, so you can all see yourselves on this map in terms of what we've highlighted, that we've highlighted some of these have the counties that have really strong outcomes and scores. And so you'll see here that San Juan, King, Whitman, Clark, Snohomish, and Whatcom were some of the top rated counties in terms of health outcomes. Pacific, Penn, Oriole, Yakima were some of the worst ranked. And then Pierce County, where we are, was really just kind of midway on the leaderboard. We're doing some things well, other things not so well. And so I think that this is a great place for us to begin really drilling down and looking at the why. And I think in all of this, with this particular use case, this is baseline data we want to add to this, but it gives us the place to really start digging in and gives us some directions to do that. So one of the interesting callouts that came from this was the fact that 30% of the counties, so 14 out of 39, had more than twice the state's overall mortality rate at 0.62%. So that was really, really interesting. And I think a good call out in terms of what data can do when we look at the aggregation. And so this specific insight to me is a place for us to begin digging in, looking at how we can aggregate other data to begin asking and answering the why question. Next slide, please. In here, we drill down further to Pierce County in particular, obviously, because Elevate Health serves Pierce County. And so what we wanted to do is to look at how we are performing in comparison to those top and bottom performing counties. And so this is a really nice snapshot in terms of looking at Pierce County, where we can start to begin to look at the gaps in our care. And this particular analysis showed that housing composition was a major area of need for us, as well as food security, at least in comparison to some of the other counties. So this is really insightful to us. We are going to begin working with the Blue Zones project in Pierce County. And so some of this information I think will be very valuable to our county as we continue down that path. Next slide, please. And here, we just wanted to take a look at the most populated zip codes in Pierce County, how they're performing against the overall county. And it was really interesting to see this call out as well, is that our top 10 zip codes, which are our most populated zip codes, are performing worse compared to the overall county numbers. And so, you know, a call out here was that access to healthcare seems to be relatively consistent. It's not perfectly consistent, but it's relatively consistent with the rest of the county. But all of our other SVI indicators are performing very poor. In particular, as I said in the previous slide, with housing composition and food security being one of the most critical areas of need for us to look at. Next slide, please. And I think, you know, really, I try to keep this really short. If anybody is interested, I have some additional information on methodology. I have a much longer slide presentation on this, and I'm happy to send that out to whoever might be interested. But we really just wanted to show you some of the work that we're doing in terms of trying to pull in some data sources and really drilling down. This particular use case looked at zip codes. Our data analysts would really like to drill down even to the census tract level, especially as we tackle work with Blue Zones and really look at those equity spaces across our work. And so hopefully this is interesting to some of you. It's really interesting to us at Elevate Health because data is always an issue for everyone in terms of interoperability and knowing what the full picture is. And so our goal is to really start trying to pull some of that data in and some of those puzzle pieces that different people across our community, different national entities may have to really better inform our picture of what's going on in the county so that we can not only do some descriptive analysis, but we can get to the point of doing both prescriptive and predictive analysis with our interventions. And that's all for Elevate Health right now. And I thank you so much for allowing Elevate Health and inviting us to come and be a part of this panel. Thank you so much.
Jody, thank you so much for that data-rich presentation. And to the rest of the panelists, I'd like to invite you back on the screen with me. And we're going to start jumping into some questions that our listeners are very interested in having answered. So first, I'd like to start with a question for Darren. And the question, Darren, is what change did providers see in their own work once social determinants of health needs started being addressed?
That's a great question. I can only speak for the providers that I work specifically with within our clinics in Clark County. They are seeing tremendous outcomes. One of the things that we strive to do is not have people go to the emergency room. And so we begin to see people attending their doctor's appointments, having a clear idea of what it is that they need from the doctor at that time, and being able to verbalize that. And just be able to communicate in their own language to an interpreter who understands and is there to support and help them has been a big shift, particularly within our Russian community right now. Our Spanish community has always kind of been there, but our Russian community is really starting to come on board because we provided them with the tools. And the doctors I work with are like, you guys are amazing. I don't know how you do this.
There's something to be said for that human touch, isn't there?
Totally. And it's just amazing. The team I work with and the staff I have are incredibly engaged with their clients. In fact, one went out to deliver some birthday balloons to someone today. So I'm happy that we're involved in people's lives and making a difference every day.
Darren, thank you so much.
Thank you.
I'm going to
Jean.
move to another question, and this one's for Lindsay. Lindsay, have you done any other funding partnerships like this one? Or what have you learned about funding partnerships like the one you shared with us?
Thank you. I will start with the easy part of this question and then pitch it to Sharon to add some context. So the easy part is yes, we have done a couple other funding partnerships since our work initially in 2019. I always tell my kids that you can, anything you're working on, you need practice. And I think that's true in the work we do as grant makers too. So our work, our initial work was a great practice session for some additional funding partnerships that we've been doing the last year and a half. So Sharon, I'll kick it to you to share a little more context.
Okay, thanks. So Lindsay's exactly right. In 2019, with the TPA relationship with our local area network pieces, and kind of practicing that, seeing what their needs were and how we communicated and shared resources and ideas was really great. When the pandemic hit, we were literally able to take that model of, oh my gosh, who can our partners be? And we stood up I'll refer to it as the Central Washington Funders Alliance, where we quickly put together United Way, ourselves, Latino Community Fund, a Tamaki Foundation, and advisory groups throughout Kittitas and Yakima County. And literally every week addressed grant needs and funding needs in our community. We looked at, and not just money, but delivering resources throughout the community. That partnership, that threading of all of those things allowed us, one, not to duplicate things, but also to really layer on funding. If one of us had a source for one thing and not another, we could see where the gaps were and say, yes, move the money out quickly. And we just handled the administration part of it, which we'd gotten pretty efficient at through our practice with Greater Columbia ACH. So that was a great piece. We have now been so successful over that in the last year and a half, moving through our organization more than $7 million in grants out to community during the pandemic. It was pretty significant amount, that we're actually going to formalize that model into something where we're going to take it to the next level with all of those funders in our community and see how we can continue to do that work over and over again. So hope that this works. Hope the relationship that we are allowed to continue with third-party administration and work closely with our local networks on that.
That's amazing. That much money spread out into a community at a time of greatest need. Thank you so much for being there for them and being able to gather those funders together and eliminate the duplication, like you said. So powerful, so powerful. I'm going to move to another question that we received. And Amy, this one is for you. There was lots of interest on the site that you shared with us. And the question really is, what process did you use to learn about the local projects and collecting the information for the inventory that you shared with us?
Yeah, so as we all know, there are many determinants of health. We could have had 1,000 categories on our map. But based off of the regional assessment we did in 2020, we were able to identify 5 categories of housing, food access, transportation, financial strain, and access to healthcare. We were able to focus in on those just based off what we heard from our community partners as greatest needs and also where the work is being done. So we started with those categories, and then we started with what we knew. We looked to the partners we already worked with, we looked into their projects, and then we started to hear who they were partnering with, and we looked into who they were partnering, kind of like a snowball effect of just like going down the rabbit hole of just being curious with it. And we built this strong foundation of the tool now that as we share it, we're creating different ways for people to engage with it, whether it's sharing their own project via the website or emailing us. So now that we have this foundation, we're trying to incorporate opportunities for people to share with us, whether it's writing a note during a presentation or an event that we're hosting. Already I've gotten a couple emails in the last 15 minutes here from people. So we started out this snowball approach, and now it's more just building those connections.
That's wonderful. Tell me this, is there any concern that it will become stale or outdated? You know, it's the flavor of the month, it's new, people are engaged and energized, but a year from now or 2 years from now, how are you going to keep that fresh?
Yeah, so it was really important to us that we're creating something of value and not just repeating other directories out there. We didn't want to step on 211's toes or anything like that. So we're internally creating a process for upkeep. And something that we've discussed, especially for the access to healthcare piece where it has that data dashboard, is looking at each of those metrics and maybe doing a deeper dive blog, focusing on what does the data actually mean, starting to tell that story. So we're definitely looking into ways to continue to tell the story in new and engaging ways, while also having an updating process to make sure we're adding projects so that it doesn't get stale or things like that, and just listening to our partners and hearing what's useful about this tool and just allowing it to be flexible and grow in the way that's actually useful.
Thank you so much. And again, as somebody who really is visual, I found it to be super engaging. Thank you so much. We have another question that came in, and Jody, this one is for you. How will you use cases like the one you presented to be utilized and serve our communities?
That's a great question. Thank you for asking that. I think any data serves our community. And so while we're utilizing Innovator as an aggregation engine, our hope is to create products with some of these use cases that we can push externally. And so we would actually like that to be bi-directional. And so our hope is as we convene community around these use cases that there's further development around who may benefit from the information we're aggregating, who may contribute to information to be aggregated, and then really working very collaboratively with the county healthcare systems, but also we would love to really have that multi-sector inclusion because we really feel that that is going to hit at social determinants of health in a more robust way. And so we are working with some larger partners in the community around a community-based CIE, but we didn't want to wait. We wanted to get started really on seeing what we could do to aggregate, and then hopefully by the time a community-based CIE is set up, we can begin pushing some products and some data to that aggregate platform. So hopefully that answered some of those questions. It's a lot of work. It's a great lot of work, and we're feeling our way as we go, but the whole point is to share it back to the community. Thanks, Jean.
Thank you so much. Anytime we can support work with data, we'll be one step ahead to help us really understand what we are dealing with. So thank you so much for really diving deep at the Pierce County ACH, Elevate Health into that type of data. So I believe most of our participants on this call know that the Healthcare Authority is working on a renewal of the existing Medicaid waiver, and addressing social needs is likely to be an important element of it. So I'm going to ask the panel, what advice would you give the state? What would you like to see accomplished on this front over the next 5 years? How should we tackle social determinants of health? What do you guys think?
I always love giving advice, especially when it's solicited. I would say, if I'm thinking about some of these community-based grant funding, I would say front load the funding and allow for multiple years to spend it. So, if there's a set amount, instead of a set amount or an equal amount each year over a period of time, front load that as much as you can so that providers, community-based organizations have the resources they need to get started. Because generally, I find that grant programs always take a little bit longer to get off the ground than anybody thinks they would, particularly in our post or during the new COVID life that we are living. And so moving that funding up front, but recognizing that time is also a commodity and allowing time to spend that down over more, I think can be really important, particularly for smaller community-based organizations.
Lindsay, thank you. That front loading can be huge. So many organizations would like to do work, but if they don't have the upfront dollars to get it off the ground, it will stop them. So thank you for that advice. Other panelists, what do you think?
Well, I can jump in here. I got a dog that's growling at me too because he can't come in here. So I apologize for that. But I think one of the things that I personally would really like to see is for the state to kind of mandate sameness within the programs, a shared community health record, one place to do our documentation. Yes, I am a social worker, so that's where my head goes, is how can I make the job for the boots on the ground easier? I think the state's really good at listening to the bigger leadership, but if they could have the boots on the ground and the consumers of what we're offering's voice included in that, I also would like a whole lot less red tape. Give us the money, let us figure out a project to do with it, and then to run with it.
Darren, thank you. The boots on the ground, the people that really are doing the work understand in a different way than people that are, managing the project. So thank you for sharing that integrated approach would be very helpful.
So I have another suggestion as well, which goes to kind of my piece I put in the chat. But for Jody and Amy, who have done this great data collection piece, we all know how expensive that research and gathering up that data is, and then actually finding someone on staff or outside of your organization to present that in a way that means anything to your community. That kind of information is invaluable to all of us as we look for how do we measure against it, but how do you decide what community and what specific demographics of community or whatever it is, especially in rural communities like ours, need that extra funding or where it goes to. And it's really hard when you just look at this blanket across the board. So I'd love to see them provide some funding for us to do this in all communities. Or can can we pay Jody to share that information with us? We know the greater Yakima County stats, but when you get down to census tract level, I'd love to see how in one side of Wapato it's different from another side, and how do we impact that, or where do we move food banks to address those needs differently, and really talk about strategy across our entire communities instead of just kind of the hit and miss and who has resources and who doesn't.
It really sounds like you're speaking to equity, Sharon. Thank you.
It is.
Jody, did you have something you wanted to share?
No, I just wanted to say, the whole goal of this is really to look at being helpful, right? And being useful. And that's to our community-based organizations, because even locally, our smaller community-based organizations don't have those resources. And so the goal would be to potentially create a model that the state could use truly, and that everyone could benefit from. And that's why we really liked the analysis of Washington State. So we could, and it's very sweeping right now, but really looking across the state and showing what we can do with some of that aggregated data. So Sharon, it is really expensive. And one of the reasons we leaned into Innovator is because we were already paying for the platform for community-based care coordination. And they do have the resources for that data aggregation. And so to us, that was smart to use the resources that we had in place. And they really are known for this, and to really lay on their analytics capabilities. But you're right, when we're looking at the bigger CIE, we've really had to lean into the community and partner, because it is, not only is it expensive, but there is a large onus of risk. And we all need to share in that risk together.
Thank you so much, Jody. Amy, any last thoughts on advice for social determinants of health in the future and the Healthcare Authority?
I would just invite the Healthcare Authority to consider local approaches in the local context, even just looking at our inventory and the different projects going on the more rural side of the peninsula versus some of the more suburban urban areas. Success looks differently in these different places across the region, let alone across the whole state. So we really just encourage flexibility to incorporate local approaches, and also just encourage community clinical linkages and partnerships where, as opposed to medicalizing social needs like so much shared yesterday in the keynote. So we just encourage partnerships and localization.
I would like to thank this panel so much for spending time this morning talking about social determinant of health needs. For those of you that are attending the symposium, we will be back at 9:45 with the next session. I hope you enjoy your break and we will see you soon. Thank you.
Hi, Amy. We're on a 15-minute break. So if you just know your audio and video is working, you can mute and close video and we'll resume at the start of the session.
Phew, can you guys hear me?
Hi, yes, Susan, we're gonna all mute and turn off video until we start.
All right, I'm going into my last patient. I'll be right back.